Dear all, and welcome to this webinar on commercial determinants of health, the impact on public policy making. This is the first webinar in a range of webinars that the Project Joint Action Prevent NCD will facilitate during the course of the next 3 to 4 years. The purpose of this particular webinar is to focus on the commercial determinants of health, which is built into the project. The project, the Joint Action Prevent NCD, that some of you might know already, is a large effort from the Commission, the European Commission, involving 25 countries, more than 100 institutions, and is lasting from 2024 to 2027, where the main aim is to support the member states in the efforts to reduce the burden of NCDs and cancers in Europe. In this seminar, we have 3 presenters. It's Professor Gilmore, Professor Karine Gallopel-Morvan, and Sara Cerdas, which is the former member of the European Parliament. So, as a starting introduction to the concept of commercial determinant of health, I will then wish Professor Gilmore from the University of Bath welcome, and please start your presentation.
Great. Can you see everything now and hear me?
It's
yes,
perfect.
Yes?
Yes.
Great. Okay. So I'm going to give you a brief introduction to understanding and addressing the commercial determinants of health. And I'm going to do this based on a recent Lancet series that we published. And there's a link to the series here. You just have to Google Lancet Commercial Determinants of Health and you'll find this series of 3 papers. And almost everything I will speak about today is detailed in those papers. So in the interest of transparency and best practice, and I would encourage all of you to start your presentations with a conflict of interest declaration and encourage others to do the same. Just to clarify that in my research group, we don't take funding from tobacco companies or any other commercial organisation whose interests are not aligned with public health. And we ensure that all of our research contracts give us freedom to publish. Full details of our funding policy and all our funders are available online at the links shown. Okay, so I want to start by thinking about the scale of harm from commercial products. So we all know that these products cause harm, and I'm sure many of you know exactly the scale of these products, but I just want you to think about the scale of harm for a moment. I've put a comparator there of COVID-19. So over 4 years, COVID-19 caused 6.9 million global deaths. At its most in 1 year, that number of deaths was 2 million. And of course, that led to a massive response. But do you know that each year, just those 4 products that I've shown you cause between 19 million and 33 million deaths? That's between 1/3 of all global deaths and almost 2/3, or between 40% and almost 80% of global NCD deaths. That scale is vast. And think about the economic cost of that harm. That is also massive. It threatens the health and productivity of our workforce. Yet compare the response to COVID, a massive global response, to this number of deaths each year. The response to this is really pathetic by comparison. And it's not because we don't know what to do. We do. In fact, the policies needed to tackle at least some of these NCDs, or some of the policies needed, are detailed in this WHO report, Tackling NCDs, which was first published in 2017 and has since been updated. And yet look at this paper by Luke Allen and colleagues last year. And this shows that NCD policy implementation has stagnated. And in areas related to those unhealthy commodity industries, like the 4 I just showed you, progress is going backwards, okay? And obviously a key difference between the COVID virus and these industries is COVID has no lobbyists, okay? So in many instances, governments may not be acting because they don't believe in intervening in the market, or they've been captured by corporate interest. But very often it's because governments and indeed public health practitioners are being misled by corporations and their lobbyists. But this is just one part of the commercial determinants of health. The problems go well beyond those few products in 2 main ways. Firstly, because there are many other commercial products that cause avoidable harm. And this includes products that should be beneficial to health, like pharmaceuticals and vaccines. Sometimes, ultimately this is driven by the drive for profit. And we know from our work on corporate influence on science, which I'll show you later, that actually pharmaceutical companies engage in the same problematic practices in science as tobacco companies and fossil fuel companies. And this alone has led to preventable deaths. Look at the COVID vaccine again. Despite public sector, immense public sector involvement in developing COVID vaccines, pharmaceutical companies used their intellectual property protections to drive up prices to make those vaccines largely inaccessible to some countries. And then there are the other key way in which commercial harm goes beyond those four products is through commercial practices, which regardless of the product that the corporation sells can also cause harm. So again, in their drive to maximize profits, corporations have successfully over time driven down labour standards. We've seen an increase in insecure and 0 hours contracts, which has significant impacts on health, including mental health and physical health. And again, we saw this in COVID-19. So not only were workers on 0 hours more likely to acquire COVID, they were also more likely to die from COVID. And average workers have not only just seen a shift to 0 hours contracts, they've also seen a stagnation in their rates of pay. Yet at the same time, chief executive salaries have been increasing exponentially. And so the gap between chief executive and average worker salaries has reached, in the words of this article here at the bottom of the screen, obscene levels. And of course, at the same time, we're seeing a shift in most countries to increasing employment within the private sector. So these patterns have an impact on inequity within countries. And then other practices can cause harm really largely indirectly. So here I turn to financial practices just as one example. And this slide looks at tax avoidance through tax havens. This is a report by Tax Justice Network back in 2020, and they estimated that globally 427 billion is being lost in tax avoidance through tax havens. 245 billion of that was through multinational corporations who are shifting 40% of all profits made abroad into tax havens. That's the equivalent to one nurse's salary every second, or on average 9.2% of health expenditure. But of course, low-income countries are disproportionately affected. So for those countries, it's the equivalent of 52% of their health expenditure, compared with 8.4% in high-income countries. And yet most of that tax abuse is facilitated by high-income countries. So all of this and more falls under the umbrella of what we now refer to as the commercial determinants of health. So broadly speaking, the commercial determinants really just refers to the way in which the commercial sector impacts on health, both positively and negatively. And so it's an extension of what we've traditionally referred to as the social or political or economic determinants of health, and simply recognises the growing role that commercial actors now play in society in terms of housing, healthcare, education, employment, all factors that have an impact on health. But in our Lancet series, we outline this more specific definition, the systems, the practices and pathways through which commercial actors drive health and equity. And by health here, we refer to both human and planetary health, because those two are totally interconnected. And we're really flagging the impact on equity because that's important. So just to flag a few things about this definition. First, it's neutral. It doesn't specify either negative or positive outcomes. And that's because, as those images below illustrate, commercial actors are in fact incredibly diverse. Some will be damaging to health, but some will make, of course, positive contributions to health and well-being. And some are going to be providing solutions to the problems that we're facing. And it's also worth remembering that small and medium enterprises make a disproportionately high contribution to economic growth, inclusive economic growth and employment. And very often they're the victims of the same system that's driving the commercial determinants of health, because they don't have, for example, the scale to engage in the tax avoidance strategies that I just illustrated to you. Okay, but the other key thing that we're highlighting in this definition is that the systems element. So what we go on to do in the paper is develop a model of what we call a pathological system. And I'm not going to go into this in detail here, but what it details is the commercial sector and the practices that commercial organisations engage in. And then it goes through the ways in which it can impact on health in the rainbow model that's very deliberately based on the Dahlgren and Whitehead model. But what I want to draw your attention to today is these two elements. So what we show is that through these commercial practices, commercial actors are trying to shape this whole system in their own interest. And at the same time, governments and intergovernmental organisations, the European Union and so on, often enable and empower rather than regulating those corporations and holding them to account. And so we end up with a system problem, and it looks like this. I'm trying to see if I can get my... No, I can't get my... so if we start on the left-hand side with the dark blue circle, with the advent of neoliberalism in the late 70s, we saw a shift towards larger and more powerful transnational corporate actors. And they use their power to shape norms and shape policy and regulation. And I'll come on to illustrate both of these. And that leaves them both able to increase sales and reduce their costs. And both of those can lead to harm. So for the unhealthy commodity industries like tobacco and alcohol and so on, obviously the greatest harm comes through driving up sales. But for other industries, the greater harm comes through cutting costs, for example, cutting labour costs or cutting corners on supply chains, leading to environmental damage. So harm occurs through both of those routes. And if we move to the green circles on the right now, obviously someone needs to meet the costs of those harm. Corporations are not meeting those costs. Instead, governments and individuals are meeting those costs. That reduces the money they've got available to spend on other issues like housing and healthcare at the top of the circle. And in turn, that, of course, compounds and increases the harm. And so that the risks, the losses, the costs are socialised. And meanwhile, if we go back to the left, those corporations who are not meeting those costs are, by definition, therefore making excess profits. And in turn, the circle continues. So the profits are being privatised. We have the winners on the one side and the losers on the other side. So let me go through that a little bit. So norms are social expectations about how individuals, communities and organisations behave. And commercial actors, of course, they respond to norms, but above all, they seek to shape norms. This requires huge resources, and norm shaping is really the most hidden form of power. And one of the norms that corporations have been shaping is the deregulation. So this drive to deregulate, and rather than regulation, to focus on partnership approaches. And here we've got the example of the World Economic Forum, and we need to remember the World Economic Forum actually was, at least in part, established by major corporations as part of their drive for neoliberalism. And I've taken this from the World Economic Forum website, why we need public-private partnerships to address the global health challenge of obesity. They're arguing no country, company or institution can tackle obesity alone. But let me make absolutely clear, there is no evidence for these partnership approaches. If anything, the evidence is quite clear that when there is a conflict of interest, as there is between a multinational food corporation and efforts to reduce ultra-processed food use, where there is a conflict like that partnership approaches do not work. And yet we're seeing time and again these partnership approaches. I even go to public health conferences where I hear people say, oh, well, we need the food industry at the table. You absolutely do not need the food industry at the table. In fact, the evidence shows otherwise, that if you have the food industry at the table, you're not going to make progress in addressing this. The other norm they shape is they try and frame public health problems, so complex public health problems, as the problems of a few misinformed and irresponsible consumers. And that's, of course, to hide the role of industry, but also to push for a focus on individual solutions, because, of course, individual solutions are far less likely to have an impact, particularly if we don't change the environment in which people are living. So here's an example. This is Pepsi Cola, the chief executive of Pepsi Cola, saying, if all consumers exercised, did what they had to do, the problem of obesity wouldn't exist. But yet, as I show you on the right, over 50% of EU citizens have either overweight or obesity. You know, if this was a problem of a few individuals, how would the scale of overweight and obesity be that large? In Mexico, 73% of the adult population are overweight or obese. And the increase in obesity followed the North American Free Trade Agreement and the opening of the Mexican market to the soft drinks manufacturers. So these are not the problems of a few individuals. These are system problems. Okay. And again, as I've said, a key reason for blaming individuals is to push us and to push governments that tackling individual behaviour change is the way forward. Of course, that plays a role. But if you don't also change the environment, making those behaviour changes becomes incredibly difficult. And that's an incredibly expensive way to try and address this problem. We also need to change the policies. We need to regulate, to change the environments in which people live, to make healthy choices, if we want to call it that, you know, feasible. So let's turn now to look at why, you know, I've already told you that the policies we need are not being implemented. And a key reason for this is some of the practices of commercial actors, particularly their political and their scientific practices. So by political practices, you know, we refer to lobbying and a whole host of different practices. In the papers I've detailed there, we've actually developed models and taxonomies of the practices that corporations engage in based on, you know, vast amounts of evidence. And what these two papers show, one looking at political practices and one at scientific practices, is that diverse industries use the same practices. It is not just the tobacco industry that lobbies to oppose policies or manipulate science. And yet it's only the tobacco industry that we really hold to account for its practices. In fact, in our work on political practices, what we show is that across tobacco, alcohol, ultra-processed food and gambling industries, their long-term objectives include normalising industry as an essential policy partner, trying to disenfranchise and disempower public health, trying to constrain public health as non-regulatory and individual-focused, and to change systems of policy making to make it harder to regulate. And here I'm talking, for example, about better regulation. So as you know, better regulation is, you know, the approach to policy making in the European Union. And work we did quite a long time now, based on the tobacco industry's documents, showed that the tobacco industry, working with a whole host of other industries, food companies, alcohol companies, chemical companies, for example, they used those political practices to establish better regulation because they thought it would work to their advantage. And they did so deliberately to make it harder to pass public health policies. And we've gone on to look at what impact that has, both at European Union level, but also in the UK, where we have the same rules. And just as industry predicted, these policies work exactly as they intended. They do make it harder. They make it easier for the industry to influence policy and make it harder to pass public interest policies. And in large part because there's a requirement for early consultation with affected stakeholders, which advantages these powerful commercial actors because they use it as an opportunity to feed in their, what they might call evidence, but we have shown time and again is actually often incredibly misleading. And it also has a requirement for business-oriented impact assessment, which again tends to advantage businesses. So the situation is getting worse. Let me give you just a couple of slides to illustrate that. And these also help illustrate the fact that we have got this system problem. So from the late 1970s, and remember, this is a period over which harm from these products has been increasing, with the exception more recently of tobacco, and I'll come to that. So since 1990, for example, rates of obesity among adults globally have doubled and amongst children have quadrupled. And yet over this same period, this paper by Wood and colleagues shows that effective tax rates on US-listed unhealthy commodity industries, so ultra-processed food, tobacco, fossil fuel and alcohol corporations, has been falling. And that wealth, instead, it wasn't out of the system. Instead, the wealth and income from those products was being transferred to shareholders, and their shareholders were increasingly in the West. So those corporations have distributed much less of their wealth and income to governments and much more to shareholders and investors. And so, in part as a result of this, this is a graph from the World Inequalities Report, and it shows over almost the same period that overall nations have become richer, but governments have become poor because the proportion of wealth that is in the private sector has been increasing, while the proportion of wealth in the public sector has fallen. And since COVID now it is negative in some countries. And of course, this has got implications for how governments can address poor health and climate and inequity. And unless they do something to address this system problem, they will be increasingly beholden to these corporations that are part of the problem. So there is an urgent need to act. Okay. So in terms of what do we do? We need to address NCDs on the one hand, and we need to address the system problem on the other hand. So in terms of addressing NCDs, we need to learn from tobacco control. This is often referred to as the poster child of the commercial determinants of health because it's the one area in which significant progress has been made. We have addressed the tobacco epidemic, and we have addressed its corporate vector, the tobacco industry. Because Article 5.3 of the Framework Convention on Tobacco Control recognises the conflict between the tobacco industry and public health. And the words of that article are there. It requires governments that in setting and implementing their public health policies, they need to act to protect those policies from the vested interests of the tobacco industry. And as a result, as I've shown you, I haven't shown you actually, I have got a graph on this coming up, that, globally, cigarette sales have been declining and smoking prevalence has been declining at a time, for example, I've already told you, but obesity rates have been going up. So part one of our response needs to be to address non-communicable diseases and these other unhealthy commodity industries. We need to move beyond what we call tobacco exceptionalism and stop ignoring the overwhelming evidence that these health-damaging industries all engage in the same practices. I've shown you that there is a fundamental conflict between their interests and public health, just as there is for tobacco. And so we need a conflict of interest policy, just as we do. For tobacco, we need an Article 5.3 for these other industries. We need to exclude them from policy formulation. We can think of policy development as in formulating policy and implementing policy. And when it comes to implementation, it can help to consult with commercial actors. But they are not the experts on policy. We are the experts. Governments are the experts. We need to be helping design the policies. We also need to recognise the evidence that voluntary and partnership approaches don't work and that individual level measures are insufficient. We need to regulate. And of course, getting regulation through requires effective advocacy and particularly policy advocacy. So I've told you about the progress in tobacco control. This is a graph showing global cigarette sales have been declining. But you can see here that in the last few years, progress has stagnated. We're seeing the same in global smoking prevalence. So the global burden of disease data shows that the rate of decline in smoking prevalence in every world region is now slowing. And this is because we have failed to address the wider system problem that drives the commercial determinants of health. And this means that when you squeeze the profits of a major corporation like the tobacco industry, just as you would squeeze a balloon, they will find profits elsewhere from e-cigarettes, from new nicotine products, etc., as we're seeing now. And we haven't addressed that yet. We haven't addressed the power of these industries. We haven't addressed the externalities. We haven't addressed the excess profits. And until we start to address those problems, it's going to remain incredibly difficult to address the commercial determinants of health. And my experience of this was that we now have plain packaging of cigarette products in the UK, but that took 8 years from start to finish. And it was a massive battle because the tobacco industry, despite Article 5.3, despite a committed government, will fight tooth and nail to try and stop any policy that affects his interests. And we don't have time to take 8 years over every NCD policy. So at the same time, we need to start thinking about how we address the system problem. And this involves, amongst other things, the issues outlined on this slide. So we need to start rethinking the way that capitalism is organized. And above all, we really need to think about moving beyond GDP. This focus on GDP has led to unsustainable economic growth that doesn't account for the environmental or health harms. Every financial transaction, whether paying for healthcare or to clean up an oil spill, contributes positively to GDP. Whereas other things like looking after children in the home or looking after older relatives, because it doesn't involve a financial transaction, doesn't count in GDP. So we're valuing very often the wrong things. And there are alternative economic models, for example, donut economic approaches or well-being approaches. And we need to start thinking about how can we harness these. We need to rethink approaches to policy making to ensure that it works in the public interest. And this requires addressing the rules on policy making, like better regulation, and the rules on engagement in the ways that I was talking about, formulating policy independent of industry. And it also requires us to address power asymmetries. And a key way to do that is to move to full cost accounting in order to try and ensure that these corporations causing harm meet the costs of their harm. And then we need to remember that governments and the European Union, they do have power. They have regulatory power and they need to use that power. They're actually obliged to protect health. It is a human right. And we need to collectively push for these changes and reframe these issues in order to get there. And of course, that requires effective advocacy. So one of is my last slide.
Thank you.
So what worries me is this, that we've got the European for Health programme, 5.3 billion initiative from 2021 to 2027 to strengthen healthcare systems, promote disease prevention and improve public health across Europe. But let's look at the budget there. I've detailed that, the 2024 budget of 752.4 million. Just 1% of that budget goes to NGOs, and that's NGOs covering all health and public health initiatives. I don't believe we're going to get policy change unless we're funding the advocacy NGOs on a sustainable basis. I'll give this a miss. I'm going to leave you in the words of Jeffrey Sachs, who said at that UN pre-summit on food systems, the private sector is not going to solve this problem. The key for the private sector is simply this: behave, pay your taxes, and follow the rules. That's what businesses should do. We all need to work collectively to address the commercial determinants of health. Thank you.
Thank you very much, Anna, for this brilliant presentation. I think you really set the scene about how the commercial actors and the role of and impact they have on health and how they determine health. I think we just continue with the next presentation, and if there is some time in the end, we'll just ask a couple of questions. So then I will ask Professor Karine Gallopel-Morvan to present. She is working at the National Institute for Public Health in France, and she is also working within the Joint Action, and she will present more on that herself. Please start.
Thank you. Can you hear me? Can you see my screen, my slides? Is it okay?
Could you please put your slides back on? Let's see. There we go. Thank you so much. We see it. Thank you.
It's okay? Okay.
Yeah.
Well, good afternoon, and thanks a lot for your invitation. So I work in France, and just for the conflict of interest, we are all our research is funded by public health institutes in France, and we have no funding from private companies. My presentation will focus on one topic we deal with in the GA, because I lead a subtask which aim is to analyze the effectiveness of alcohol warnings in Europe, and also to analyze commercial determinants of health. So I will ask the question, why have few countries adopted effective alcohol warnings? today, and the role of commercial determinants of health in answering this question. I won't get into details on the harms that alcohol causes, because you all know this by heart. So we know that there is different measures to tackle these issues that are recommended by public health actors, and that are detailed in this global alcohol action plan of the WHO. I will focus on one measure, which is the Article 11 of this plan, that is about alcohol health warnings. Today, we know, well, all public health actors, they recommend mandatory health warnings that could be displayed on alcohol containers and also advertising when it's not banned, including WHO, but also NGOs in different countries in the world. So it was also a measure that was recommended in the Europe's Beating Cancer Plan. It was recommended to adopt mandatory health warnings on labels before the end of 2023. Well, we have no news about it. It's not the case for the moment. The reason why public health actors recommend to adopt alcohol warnings, it's because we have quite a lot of evidence based on the effectiveness of this measure. There are more than 80 studies that have been published in the last decades to see and to present how this measure is effective on effective population level strategies on different outcomes, including increasing knowledge and awareness of alcohol harm, changing beliefs, attitude and image of alcohol, and also influencing behaviors. But these outcomes can happen if alcohol warnings are sufficiently visible, easy to understand, clear, credible, break the marketing effort of the industry on packaging or on advertising, rotated to prevent from weariness, targeted to people they target, and combined with pictograms and photos. And if they are mandatory self-regulation, we know that, and Anna talked about that before, self-regulation is not effective at all, including in the context of alcohol warnings. And if warnings are chosen by public health actors, because warnings recommended or messages recommended by alcohol industries like consumerist moderation and so on, these kind of messages are not clear at all and not well understood by people. And I would like to add that it's free for governments to adopt and to display these kind of warnings on the alcohol containers or on advertising, compared to very costly mass media campaigns. So the question now is, what is the current situation? Because we have the evidence-based, a lot of public health actors recommend to adopt the measure. Well, the current situation is not that much wonderful, because we know that most warnings displayed on containers and ads, they are not evidence-based at all, and they are not mandatory. Here are some examples of warnings displayed on ads or on containers, which are barely invisible and text only, not clear, and so on, so far from the evidence, the scientific evidence. And a document of the WHO in Europe noted out that in 2024, only 13 out of the 53 member states of the WHO European region had mandatory health warnings on alcohol labels to inform people about the risk associated with alcohol consumption. So how to explain the current situation? The evidence base this here. So the only explanation is that there is a very strong lobbying made by the alcohol industry when effective warnings are planned and mandatory warnings are planned or discussed by countries. We had a very interesting examples that actually effective warnings will be adopted in the future by Ireland in 2026 and by now has been adopted by Australia regarding warnings on pregnancy messages, but it took a while. It took several years for these two countries to vote these warnings due because of the very strong lobbying by the alcohol industry. So it's very crucial. So researchers, they conduct a lot of research on the effectiveness of alcohol warnings, but it's very crucial to analyze too, in combination to that studies, the way the lobbying of the alcohol industry against different measures, including the alcohol warnings. To my knowledge, for instance, regarding the question of alcohol warnings, there are only 3 research studies that was conducted around the world on the arguments and lobbying of the alcohol industry against the implementation of mandatory and effective alcohol warnings. So we did it in France some years ago. I published a paper with a colleague of my school, and we analyzed in 2 decades these main arguments put forward by the alcohol industry based on French press articles to struggle against the very tiny warnings that you can see here that is displayed on alcohol bottles, and it was planned to enlarge its size in 2018. It never happened because there was a very strong opposition of the alcohol industry to enlarge it. So we analyzed in the press the different arguments provided by the alcohol industry against that measure. And I will show you in the next slides the same sorts of research in Australia, in New Zealand, and also in Ireland and in Canada. And it's always the same arguments. The alcohol industry say that it was an exaggeration of the problem because it was disproportionate to say that alcohol kills. Another argument, very common argument, is to say that alcohol warnings, but also advertising ban and so on, is not effective to change behavior. It's all people know, all women know that it's not good to drink alcohol, so it's not necessary to display a warning on that. The alcohol industry also focused on the counterproductive effects on the economy because it's a very high cost for producers to display warnings, and it's a big issue because it attacks the wine sectors and other producers. And instead of that, this tiny warning, and we are speaking of that, the alcohol industry in France recommended to use alternative proposals, which is to speak of responsible consumption of or moderate alcohol consumption instead, and even benefits for health instead of warning people on harms. To conduct by the alcohol industry should conduct that with collaboration of governments, NGOs, preventive programs that target pregnant women, or that could include health professionals too. And also the alcohol industry recommends collaboration prevention because they are part of the products, the alcohol consumption, so they must be involved, the alcohol industry must be involved on prevention, and including alcohol warnings. Just a few slides to present you the arguments that were used in New Zealand and in Australia to struggle against the warnings that was adopted actually in 2023, and that were noted out and presented in the Food Standard Australia and New Zealand reports. So it's about the same about then France. Among the numerous submissions made by the alcohol industry, there were a question on the scientific evidence of the effectiveness of warnings on behavior, the potential negative effects on the pregnant woman health, because women should be stressed because of that messages. A recommendation, and the alcohol industry won that because at the beginning it was planned to use health warning instead of pregnancy warning, but the alcohol industry said that it would penalize the whole population, and it would be better to use drink responsibly, and then the focus was the selected messages was pregnancy warning. And the alcohol industry was also concerned about the format of the new warning regarding capital letters, size, which is judge excessive if the pictogram was necessary, and about the red color too, which was a high cost for the alcohol industry. Of course, like in France, the alcohol industry focused on negative consequences on the economy of the alcohol industry. And they also questioned the benefits of mandatory warnings over self-regulation because they are responsible companies. The last presentation, a very quick presentation on the research, which aim was to focus the framing of news coverage of alcohol warnings label initiatives that included a concern message on alcohol containers in Canada and Ireland. Industry arguments opposing concern warnings were very similar across Ireland and Canada that were analyzed in this paper. And also, if we compare with France, Australia, and New Zealand that I presented you before, their arguments were very similar too. Examples of that, this is a table provided by researchers with the main arguments of the alcohol industry against Irish and Canadian concern warnings. It is misleading. Stating alcohol can cause cancer is misleading. It's not really true. Warnings are ineffective, and there are anti-trade alternative measures that industry supports. They can cause hurt or disadvantage alcohol industry and will cause stigma. Among them, there are disproportionate response not required in other countries, and it will be too expensive and logistically complicated to implement. So about the same arguments then in France, or maybe some adaptation regarding the countries, but about the same arguments then we highlighted in France and or in Australia or in New Zealand. So as a conclusion of that, we know, like Anna mentioned, that the main problem with extending alcohol warnings worldwide, like other effective measures, health measures, is that it's not scientific evidence that we have now, but that's the industry. We know very well with the too little research on alcohol warnings, but we have a lot of research on tobacco taxation and so on, that the alcohol industry adopts international lobbying strategies with local adaptations. So, for instance, in France, front groups were wine producers because their image is very good in France. It was the case with whiskey in Scotland, for instance. The alcohol industry uses taxes very similar to those used by the alcohol industry, by the tobacco industry, the food industry, and so on. So it's very crucial, and we try to do that in France, like in other countries, to raise awareness of these lobbying strategies or arguments among public health actors, NGOs in different countries, journalists, citizens, to denounce this lobbying, politicians, MPs who, for some of them, have direct contact with the alcohol industry. I don't know in other countries, but in France, I'm very amazed to see that these people, including public health actors and NGOs, they are very naive about these lobbying strategies and arguments of the industries in general. So it's very important to give NGOs and public health actor advocacy skills to resist the industry's lobbying alcohol or other industries, and to ban, of course, alcohol industry representatives from engaging in health policy decisions. The 5.3 article of the FCTC should be applied to other private companies that cause health harms, of course. And another recommendation is to increase transparency about links between the alcohol industry, elected representative, and governments. In France, we are very far from it, and we are conducting the research at the moment on beliefs and images of alcohol, on different arguments on tobacco, on alcohol taxation in France, and tobacco taxation, and it's very scaring to see that what MPs think and their beliefs about that, they're about the same than the arguments of the alcohol industry and tobacco industry in France and in other countries against tobacco taxation and alcohol taxation. So thanks a lot for your attention.
Thank you very much, Karine. And I think this your great presentation exemplifies very much what Anna told in her introduction, a very concrete example. I think we just have to rush forward and introduce the next presenter, which is Sara Cerdas. Sara was a member of the European Parliament from 2019 to 2024. And the interesting thing to her, from her side, will be she will be representing the policy decision makers. So it's nice to hear from her how she has experienced these attempts from the commercial industry to impact policies. Please start, Sara.
Thank you very much. Thank you very much, everyone, and thank you for inviting me to be here. Indeed, I'm going to brief you on the other side of the coin and how is the view from a perspective of policymakers. So just to introduce myself very briefly, at 29 and in a career of medicine in public health, I was invited and elected as a member of the European Parliament. So that's where I stayed in the last 5 years. And I have worked very much in different policies, but for the sake of time and this presentation, I'm going to focus on the health part. So I was very active in the health policy within the EU. I worked closely with the EU for Health program that was already spoken here, European Health Data Space, mental health report, and serious cross-border health threat regulation, among many others. And for you that don't know the EU that much, so just briefly to explain is that the European Parliament is the direct representative of 455 million citizens, and they have co-legislative powers. So that means that together with the Council, they legislate for the whole European Union. And the one that proposes that legislation is the European Commission. So what do these 720 MEPs do? They mainly, the EU is one of the biggest regulatory frameworks within the world, and that is because of our internal market. So what we regulate within the EU also transcends our borders because of the many commercial and trade agreements that we have. In the EU, specifically in the Parliament, lobbying is a widely recognized activity, and it's actually very important for us. As you can understand, 720 people, in my case it was 705, legislating in so many topics, you need to have the inputs of different organizations. So there's a transparency register that lists any interest representative who carries activities that can influence the EU law. And you can search the register and see who are the ones that are shaping EU policy, who are meeting with policymakers. So this can be interest groups, non-governmental organization, can be industry, public affairs firms, and these professional lobbyists that mainly they are representing industry. So it's very important to be aware who you're meeting with. Usually, I had various meetings in many of my reports, but also to give me a perspective in other legislation. And sometimes I would have these public affairs firms coming to me, but they were in a secondary platform representing other representatives such as tobacco or alcohol. You also have authorities, academic and research institutions, but I need to say this, we didn't see that much of you guys there, and that was a pity, because even though there's not as much resource power, we need more science-based policy making, but I'm getting to that conclusion later on in my presentation. We also can have think tanks, policy institutes, trade and worker representatives, but also foreign governments and international organizations. And this is for you to see how it's done, this transparency. You need, as a policymaker, as a member of the European Parliament, you need to register all the meetings that you have. So this is just a screen shot of my latest meetings I have. You can see I had with one of pharmaceutical company, I had with UNICEF, I had with another company related to coffee production. So it's very diverse, but you need to register. So anyone can go there and check who is this MEP meeting and who is this MEP getting the information from. This is another part of the transparency register that is not as widely known by many of those working in EU policy, which is the meetings that you take when you're working in a specific regulation. For instance, I was working in the toy safety regulation, and let me tell you, even there, where you want safe toys for your children, we had many non-healthy lobby happening. So you can see here several of the meetings that we had and who did we meet with. And this is something that it's also important to check, for instance, who of the ones working specifically in the regulation, who are they meeting with? And why is this all important? We regulate a lot in the EU, so it's usually called a big bureaucratic machine, but we regulate in not only health policies, but also on determinants of health. Specifically on commercial determinants of health, we could do much more. Usually, when you speak about the EU and health, majority of the people would tell you, and specifically before the pandemic, they would tell you, oh, health is not a EU policy, don't bother with that. That is simply not true. As we've seen with the pandemic, there's a lot we can do to protect ourselves, but also there's the protection of public health that is a shared competence between the 27 member states and the EU. And where does this lead us? We have the power, as it was already presented by the previous speakers before me. We have the power to legislate and regulate many of the factors that can affect our health status. So this is in food labeling, where we spectacularly failed in the last 5 years. Let's see what happens now in the new Commission. But for instance, we haven't reached an agreement on food labeling. And just to give you an example, and previous speakers spoke about that, in food labeling, I was told that to have warnings in alcoholic beverage, it will be too much, that the bottles needed to be changed, and that would impact the small and medium enterprises within the wine industry in my own country, Portugal. So why am I going against my own people? So for a political person, you can sense how the industry uses the arguments against you. And in a political perspective, that you are looking for representatives that are there for 4 or 5 years, and then perhaps they are looking for re-election, this can have immense power. What we need to do is reverse the argument, but I'm going to show you just later on. We also have environmental health policies. We just had confirmation that the new EU Air Quality Directive is approved, and we try to came up with the WHO standards for air quality, and even there we had so much backlash from the same ones that still wanted to have beating cancer, the EU beating cancer plan as the big flag. So it's important also to call on the hypocrisy here, because when we talk about beating cancer, we're not only talking about beating the disease itself, but also make so that people do not develop the disease itself. And in that part, we also failed. We have the food quality, which is very important. And for instance, 1/3 of the EU budget goes for common agriculture policy. Why is this policy? Why is this commissioner for agriculture? Why are they not being spoken with by the public health actors? That's something I leave it out there. Alcohol, tobacco, sugar, alcohol, they have a complete army within the EU. I was accused, as some of you already know this, of imposing a dry law just because in one of the reports about beating cancer, I wanted to have to ask for more research on the feasibility of changing the alcohol label to have the nutritional elements. That was, that was very epic, and especially for someone like me coming from the medical field, from the public health sector, to hear those things, it was just mesmerizing to see how much the policy-making process is so further away from the research and scientific evidence. On tobacco, I met with tobacco representatives because I wanted to know what were their main arguments in order for me to work against them. So it was about vaping and how vaping wasn't as harmful for individuals as conventional cigarettes. This is very important because we managed and we wanted to, for instance, prohibit flavors that were attractive to children, such as bubblegum flavor, and that did not pass. And now we have evidence that's saying that these novel tobacco products are making more and more youth being hooked and addicted to these products. So just with my last slide, because I know we are running a bit late on time, but the discussion has been really interesting. My key message is try to change the narrative, and this narrative needs to be changed by all of us, policymakers, academia, think tanks, the different stakeholders out there. Health is an investment, and as the first speaker already said, the health cost should not be a burden only by the governments. It should also be shared by the industries, and with this, many examples can be made, for instance, on taxation. Second message is please make it simple. As you can realize, and the life of a member of the European Parliament, and I guess in any other parliament, is quite hectic. There's many legislation that needs to be out there, and they not have time or even the capacity to read the scientific papers and try to translate what the odds ratio means. So try to make your message simple, not oversimplistic. That's not what I'm saying, but make it so someone that it's not from the field can understand this. And usually, obviously, the economic part usually makes the trick. My third message is use local and regional voices with the public. Try to gather champions to make the health is an investment mandate something of a flag that can be bared by many and can actually make shape happen. Another one is the multi-sector alliances. We cannot do this only with the health people or the research or academia. We need many different stakeholders, and that's already happening. But the important message here is that the industry has not unlimited resources. I'm doing an MBA, and the resources are not limited, but they have so much more resources than what we have in the public health field. So this multi-sector alliance is important for us to make our message more efficient and gather the momentum. We had the momentum with the COVID-19 pandemic. We have a momentum now with the Irish new regulations, and these momentums can be used in our regard in order to better explain what is this change that we want. Why do we want to have higher taxes for these harmful substances, for instance, or why do do we want warnings? Why do we want people to be better, to have more health literacy? And my last message is engage with policymakers. For every 10 requests of a meeting that I had, only one will come from the health sector or from the public health sector. And that's quite astonishing. Again, the resources are very different. There's an imbalance of power here, but engage with those that are the policymaker, make the message stick, and use them as champions to have more evidence-based policies. So I finish here. I hope I make it on time for us to have a few questions for discussion. Thank you very much.
Thank you very much, Sara, for this insight in your background from the European Parliament. Unfortunately, we don't have that much time because there is other people coming into the room, but I would like again to thank you, both Anna, Karine, and Sara, for these excellent presentations, and hopefully there has been enough stuff to take forward in the different member states. I will just say in the end that in the joint action, we will continue with these webinars. The next one will be next month, will be on well-being economy. There is possible to contact us here on this emails and websites if you have any comments or requests or anything. And by that, I will just say thank you, and thank you for listening in, and thank you for presenting, and thank you for coming here in the audience. Thank you.